this week on the BackTable podcast.
In the U.S., for example, systems negotiate with insurance companies. They pay a certain amount for an episode of care, whatever that might be in whatever specialty. So like Blue Cross or whatever, there's going to be an amount that the hospital negotiates with that insurance company. They get that amount, and then the hospital distributes it as it sees fit. And so, hospitals are incentivized to keep costs low so that they can have a better margin depending on their contract with said payer. Here, the hospital spends money from a global budget. It's quite complicated, but in a simplistic way, a hospital gets a global budget, and that's supposed to cover a lot of its operations, including the OR.
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got my co-host, Amy Park, here with me again today. Amy, how are you?
Great. How are you?
Good. OR, clinic, admin, what was today?
Clinic.
Ugh, the worst. Got Dr. Jonathon Solnik here with us today. Welcome to the show. John, how are you?
I'm mighty fine. Thank you very much. Just getting over the Tamiflu, I guess. Oh, wait, that's what I was supposed to take.
Tamiflu, less flu.
Yes, sir. But I'm hanging in. Thank you for asking.
Well, no, we're happy to have you and appreciate you coming on the show. And you're coming to us from your basement in Toronto, right?
I am.
You're the head of gynecology and minimally invasive surgery at Mount Sinai in Toronto. As we like to do when we start our shows, we like to let our listeners learn about our guests. So if you don't mind taking the first few minutes just to tell us sort of how you got to be where you are and what you're doing these days.
How far back are we going? Are we going like nursery school?
It's an hour show. Depends on what else you have left.
So
if this is the bulk of the show.
Then we're in trouble. I am Canadian, born in Toronto, but grew up in the U.S., as many of you know. Most of my life in California. My first real gig out of fellowship was at the University of Pittsburgh, McGee Women's Hospital, with our dear friend Amy. She was a little resident at the time that was a fellow. So I took my first real job at Cedars. And then, I was at UC Irvine for a short bit and then moved up to Cedars out of the OC and started a family there. And then happened to marry a Canadian, sort of a Canadian.
What does that mean?
She's like me. She's a bit from all over the world, but ultimately landed in Canada. And so her family was in Canada, and we just ultimately made the decision that it was better to raise our kids near family. So like the Beverly Hillbillies, we went in the opposite direction. I had to buy a bunch of coats and shoes, and now we're in Toronto. So we've been here since 2015. Actually, pretty lucky because, unlike the States, you can't just hang a shingle or say, hey, we want to recruit someone. We're really, the words here, resource limited. So the timing just worked out quite well that they were looking for someone like me, and we were looking to come up here, and so there you have it.
What do you mean it's a little bit different? Like you can't just hang out a shingle?
Well, there are two parts. There's the community side, and then there's academic side. So to come to Canada as an American trainee or licensee, someone with a U.S. license, you have to meet the criteria. So, unlike ours in the States, 4 years, you graduate, and you can, here the residency programs are 5 years. So you have to at least done 5 years of training. But because I had a fellowship, that worked. And because I was Canadian, it was easy for me to hop over the border from a legality side of things. Like they didn't have to import me. I could just come across. But the hospitals are limited. We have limited number of ORs. We have limited number of clinic space. And so unlike the U.S. where clinic volumes and surgeries generate revenue, here it's a cost to the system. So there has to be a real need.
Do you really want to get into that? That's
of
interesting.
Course.
Yeah. So that's
we're going into the meat right away. All right.
Yeah, no. So we'll get back to the hiring, but now that you started this, if you don't mind, like this is, as a CMO now, right? That's so much of what we do is like balancing what our mission is, right? And trying to do good clinical work for our community. But it's a business. There is, you have to make money. No money, no mission. That's what you hear a lot in this business. And so when you say it's a cost center, I mean, I guess the big thing for us, it is a healthcare industry, it's a business. So we do things, we get paid for doing certain things. That money comes through typically insurance companies or the federal government to our hospital and then back to the doctors and whoever else does the work. How is that different from, we say it's a cost center? Talk to me a little bit about sort of the business of healthcare in Canada, if you can. Big question, but.
Absolutely. There are different ways of looking at it, but I think you nailed it quite succinctly in the sense that we have one payer. The U.S. has multiple payers. Both of them run the system. So there's a common bond there, like in the sense that even though in the U.S., for example, like you negotiate, our systems negotiate with insurance companies, they pay a certain amount for an episode of care, whatever that might be in the whatever specialty. So like for surgery, for let's just take hysterectomy, for example, for Blue Cross or whatever, there's going to be an amount that the hospital negotiates with that insurance company. They get that amount, and then the hospital distributes it as it sees fit. Obviously, the higher tier, better payer is going to be more incentivized for a lower cost system in the U.S. And so, hospitals are incentivized to keep costs low so that they can have a better margin depending on their contract with said payer. But ultimately, it's volumes. So if you can generate 3 or 4x in a given day compared to 1 or 2, you're going to make more money for your outlay of HR or OR time or lab or whatever it is that you have. Here, the hospital spends money from a global budget. So it's quite complicated, but in a simplistic way, a hospital gets a global budget, and that's supposed to cover a lot of its operations, including the OR. And the OR tends to be a big cost center for a hospital.
And that's based on what? Just the population it serves. Like there's 2 million people in your catchment area. Here's X number of dollars from the Canadian government to take care of all of those people and go.
It's a great question. I don't have an exact answer for. A lot of it is historical, and that's where a lot of negotiating with the ministry, that's called the Ministry of Health, comes into play. So I imagine that some of that has to come with the capacity of the hospital, not just the catchment. So where I work in 2 hospitals, and they're both quite niche specific, and luckily both of them very much empower those of us who take care of women. So very lucky. But they're very niche specific. They're not general hospitals. Like we don't do trauma, we don't do cardiothoracic surgery, for example. That's right across the street. So the hospitals here, at least in downtown, the core academic hospitals, they try to distribute who does what so that there's not a lot of overlap. But our hospital is relatively small, and so our capital budget is going to be small in comparison to Toronto General Hospital, which is across the street, that is a bigger footprint. Same catchment, bigger footprint. A lot of it has to do with that. But then there are other parts of the puzzle where, like, cancer care gets a little premium on top for each episode of care, or there are these things called quality-based programs, like hysterectomy for benign disease falls into that. You have to meet a certain number. The QBP actually was designed around, my understanding, episodes of care. So, you get like $35,000. We don't get that much, but $35,000 for a hysterectomy from beginning to end, including all complications and things like that. That's what QBP was initially supposed to be, but it didn't work out like that. But we're still incentivized to keep costs low so that that margin of how much we get isn't eaten up by what we spend. So by law, hospitals in Canada have to have a balanced budget by fiscal year end. So if you're over budget, you're in trouble. We're usually not. So we have to either play catch up or redistribute what things we need to, like, let's say, for example, one of those QBPs, let's say we're down for hysterectomies. We're not meeting our numbers. Towards the year end, we have to catch up on hysterectomies so that we're funded the same for the next fiscal year. If we underperform consistently, we might be defunded. So let's say you're given whatever number of dollars to perform 300 hysterectomies, but then you're really only hitting 170 for a couple years. They may bring you back down to 200 or something like that. We perform well, so we're not worried about that. But that's sort of how our system works. So we're not incentivized to do more. We're incentivized to do the right number.
How about increasing the numbers? Can you ever say, hey, there's a lot of immigration to this area and a lot of younger folks who have hysterectomy or need treatment for the bleeding or whatever it is.
Not sure where you live, but people here don't really want hysterectomies unless they need to. No, I'm just kidding. It's super regional. No, we really do. We see a lot of women who are like, well, why do I need a hysterectomy? My uterus isn't broken. Ma'am, I'm sorry to say, but you have endometrial cancer. I think you need a hysterectomy. But so there's a lot of education actually in that end. But it's a good question. We actually do. So our department, we've actually overperformed in that sense in some ways because we've also built a brand. So before I came here, the idea of brand wasn't really commonplace. And for that matter, robotics wasn't even commonplace. But again, because why would we do more? We don't want to do more. We want to do the right kind of stuff. And our right kind of stuff is tertiary, quaternary level care. Like you guys, we don't see too many straightforward cases. Like it depends on our division, but our division at least, or department, we tend to do a lot of high acuity stuff. So we tend to, as you build brand, as you know, then everybody wants to come. And so we've done a good job at that. And so we have increased volumes. And so we push them through. And as a result, we try to negotiate with the ministry to increase those numbers. So, but we can also play around with the numbers in the sense that, let's say, there's institutional numbers of these QBPs, which are, again, these additional funding outside of the global budget. So let's say you're underperforming in certain areas and overperforming in others. As long as your numbers even out, then there's a little bit of leniency for that in the sense that, you can make up in certain areas and less so in others. But it's not huge, Amy. Like we can't say, oh, we're going to do 1,000 next year. They're not going to go for that. We're going to eat into our global budget if we do that. We can't super perform.
I find this super fascinating because the other piece that I was curious about, and this is like this in Korea where there's an academic side and there's a private side. I heard people have sort of private practices too. And Cleveland Clinic London is like that too, where people all work for NHS, National Health Service, but then they round in the morning and they train the residents and medical students. And then in the afternoon, they come to their private clinic and then people are paying like cash for immediate access. Can you explain a little bit more about that side?
I actually saw the Cleveland Clinic UK London when Tommaso was there. I was there for work and I reached out to him. They had not yet opened, and so he invited us over to take a look.
Oh,
wow,
cool.
So beautiful.
Yeah, I heard it's really nice.
So there is no effective private practice here in that regard. The way that the ministry looks at it is that if it's an essential service, and gynecology is an essential service, then it all is funded under what's called OHIP, which is Ontario Health Insurance Plan Program. And so anyone who does a hysterectomy or anyone who does endometriosis surgery, they're going to get the same amount no matter who they are. It doesn't matter. There's a lot of study on gender in this regard as well. Actually, some of our colleagues are doing that. But like you get paid the same no matter what city you work in, what hospital you work in. As long as it's within Ontario, it's going to be the same. So the difference is that if it's not an essential service, so dermatology, cosmetic surgery, labioplasty is included in that, or some other odds and ends, you don't do them in a hospital, then you can, and it's outside of the OHIP schedule of benefits is what it's called, then you can do what you like. But there's no private practice for what we do.
Doesn't exist at all.
Doesn't exist at all.
I thought people had their side gigs or whatever, side practicing.
If you're doing CO2 laser therapy or, some of our Urogyn colleagues do, or if you're doing labioplasty, cosmetic stuff. But those are in surgery centers that are unfunded. They're not, they're covered by overhead from the cosmetic procedures themselves. So the difference is that the anesthesiologists who work in those, they can bill OHIP usually. So because it's either that or they might have I don't know if that's true. I think that they might get a fee for what they do. I'm not sure. Don't quote me on that one. I'm not an anesthesiologist, but I can't just open up a private clinic and do the same thing. Nor can someone in private practice So there's private practice versus academic practice, same fee.
By the way, I just want to inject here that given recent political events, all these Facebook groups are like, can we go to Canada and can we go to New Zealand? And what you're telling me is X-nay on Canada.
Right now, they're up there screaming, build a wall.
No, I know the 51st state thing was not very popular, so I'm sure they're not embracing U.S. citizens with like open arms, but...
I would love to have you here. You joke, but there are a good percentage of Canadians who would not mind being ingested, or especially in the great province of Alberta. So Alberta's kind of like our Texas. They tend
Wild
to be
West, oil,
cowboy. And so their primary source of income is natural gas and things like that. And yeah, they wouldn't mind it. I mean, I think, again, don't quote me, but around 30% of Calgarians wouldn't mind being annexed. It's a mixed picture. There are some people who are okay with the idea. Because if we're going to talk about politics, I mean, the North American political systems have just kind of failed as well. Like Canada's not in great stead either.
I mean, we can certainly talk politics, but I think in terms of how it relates to healthcare specifically, because I am intrigued by this idea, yes, we have to produce and volume drives money, but in many ways it's the same problem to solve, as we have a college of medicine in a hospital, right? So the hospital is the system that physicians work in. They're incentivized for volume, and they have some quality metrics involved, but in general, it's volume. And the hospital is trying to figure out the quality piece, and it's sort of two arrows in the opposite direction. Whereas I'm wondering in a Canadian hospital, and I'm generalizing obviously, but at least in your experience, because in a sense, the budget is fixed, more or less. You said these other QBPs that allow you to kind of, if you do extra work, but ultimately, like, this is the budget for the year. Does that mean physicians there are much more likely to be interested in standardized care, like efficiency? Like if we're all in this together, where we are getting people to do this, two people to do the same thing, it's like, forget it. So is that more of a collective, like, all right, guys, come on, let's save money. We're all in this together. Is there any of that collective nature among physicians in any way that you didn't see it when you were here?
I'll back it up a little bit. I think the idea of standardizing healthcare activity, the idea of the chop shop versus the, specialized centers versus the routine, like, is 80%, what number is the right amount to standardize care? Someone with chronic AUB, it should be a fairly straightforward evaluative process. The treatment options should be roughly the same, given the average person coming out of a contemporary residency program, all that type of stuff. And versus the physician who believes, well, I'm going to do it the way that I like it because this is either how I was trained and how I'm comfortable doing it, or this is the art of medicine. Why should I subscribe to the guideline, for example? So it's a little bit of both. I would say physicians in Canada and physicians in the US are fairly similar in this regard. There's a lot of relative adherence to guidelines. So like if the SOGC, which is like the equivalent of ACOG, comes out with a guideline, the average OBGYN probably is aware of it. Whether they follow it or not, it's hard, you'd have to do a survey to determine that. But I would say it's very similar to what you would experience in an academic center in the US.
I guess the question I ask is, we think about many of our academic centers and big hospital systems are RVU based, meaning like you do a hysterectomy, make a certain number of RVUs, and somehow that's tied to your compensation, whether it's a minimum number and bonus or just, RVU per dollar. Is your 300 hysterectomies a year, that's for you personally, that's for your division? Does it really matter who's doing it? It's just like a global group. Does one surgeon get paid more for doing more? Because again, I think, for example, if someone's going to do hysterectomy, but I can't do it laparoscopically, it's too big for me, I'm going to open. I'm incentivized to keep that surgery to myself in America, right? I'm incentivized in most traditional payer situations or most traditional compensation situations. I don't want to lose money. It's coming to me if I do the surgery. Versus whoever does it doesn't really matter. We're all getting paid kind of what we were getting paid, regardless of who does it. Is there as a direct line from like fee for service, in a sense, is that model impacting care in ways that we see it here?
So this is a different question from what you just asked, as far as the collective nature of practice. We are a fee for service model. So you eat what you kill, even if you're in an academic center. So a lot of
individual. Okay, so this is individual. Systems versus people. Okay, go ahead. This is interesting.
So you take a community group practice. They don't truly exist in the sense that you might have a group of people that share call or do something like that, but they have their own independent corporation and they bill independently. So it is what is favored here is a low complexity, high volume practice. Full stop. It does not favor highly complex, low volume. So the academic surgeon, for example, who focuses only on highly complex, will suffer in comparison financially short certain services. Like there are certain, just like the US and lobbying for different, right? Women's health here is underfunded compared to urology.
So all of those things are the same, right?
Those are the same. Orthopedics reimburses well. Obstetrics, particularly at night, reimburses well. So this is why we struggle to subspecialize and focus on our subspecialty. So the average urogynecologist in the community, Amy, will do obstetrics. Do you want to barf now? The average MIS trained surgeon, academic or otherwise, is going to want to do obstetrics. Now, they might like obstetrics, it's true, but the nugget or the carrot is obstetrics. And so, and most departments or practices usually need someone to cover obstetrics call at night. So it's a win-win in many senses, but we're seeing more of our graduates who want to do less obstetrics and focus on surgery.
Are you doing OB? Or are you?
What? I haven't. So during the pandemic, we assisted on some C-sections. I had totally forgotten what all this fluid thing is, like amniotic fluid. I hadn't been in a delivery since
the baby's
my child.
In where?
Right. Bladder blade? C-section? What? It's very bloody. Anyways, no, I don't deliver babies. I haven't delivered a baby for many, many moons.
I think that's a similar conversation I've had with a lot of our colleagues about sort of the national landscape for gynecology. And by being tied to OB, forgetting urology and all the other services, just being tied to obstetrics devalues what we do because it reimburses more interest for providers to do it. More people want to do it in the community. There's less money for it. And so it's actually like by splitting it off completely, there are some folks who think it would be better for GYN, for just general GYN services by having it be separate. And I think there's interesting things about that. But yeah, I mean, I think that's very similar. So it's interesting. The hospital system is, here's the budget, low cost, yet you're, as individual surgeons, incentivized to be high volume, low acuity, high volume, financially incentivized.
And for provision of care, look, there are, in our system, the number of people in need of our service versus the number of providers is very different from the US. So you have built-in competition. If, for example, you see a specialist and you don't like that specialist, you can go see another specialist two steps away, right? Here, it's not so easy. So what happens is you have a built-in bottleneck of people who need a service and the limited number of providers who can provide that service. And the reason why it's limited is what I was explaining before, because there are only so many hospital beds, only so many ORs to be able to provide that service. So it is in that sense, a true bottleneck is what we have. So we do still have to provide the care. So, which means you end up with things called wait times. So how long would you guess it takes? I'll use my practice, regular elective, nothing emergent. We also do cancer stuff here, by the way, which is different from the US. So our oncologists, unlike the US, who are motivated by volumes as well in a system, RVU stuff. Here, there are groups that are semi-salaried here. Actually, in oncology, to a large extent, is salaried. So they work hard. They're bound by volumes, or not RVUs per se, but volumes. But they really only have the capacity to take care of high-grade tumors. So we also share that burden of low-grade cancers, or like ORADS4 type pelvic mass, things like that, which is kind of scary, right? We see a lot of abnormal pathology post facto. So
your wait time is probably what, 9 months?
I wish. So about a year ago, I would have said to someone, a new consult is about 2 years.
What?
Get out.
Get out. It's
2
horrible.
years.
2 years.
From like I'm calling
What?
to be evaluated to the time I actually get my surgery is 2 years.
But we've been lobbying. And so both hospital system and ministry and some support and financing. And we've had nursing shortages too, which I believe you are as well. So it was really bad. The pandemic recovery was not really a recovery. It was amassed more than half under experience for patients, and stressful for physicians, because then, you have this like tsunami of people waiting, and every day it's, trying to manage the expectation and take care of people, managing anemia, chronic pain. Like, it's really hard. So now it's probably somewhere between a year and a half. It's different for different people. You might find someone in the community, it might be 6 months. It's varied. Our particular system, our organization, it's quite bad just because of the uniqueness of some of the stuff that we do. So, but also our urogynecologists have the worst wait times. It's really bad. And there aren't that many academic urogynecologists, but theirs are worse than mine. So right now we're prioritizing urogynecology. We're making sure that we improve wait times for our urogynecologists and our urogynecologic patients.
Is it more an issue of people, or is it more an issue of there's only so many ORs, only so many nurses, only so many anesthesia providers? We'd love to get you in, we just can't. Hiring new surgeons, and that's another thing, right? So College of Medicine hires a surgeon, and the hospital's like, where would you like us to put them? We don't have a clinic or nowhere to put them in, and you just hired them. We work with our college to try to, mitigate those issues, but like there are different bottlenecks. Is the bottleneck for you guys primarily just hospital beds, OR time, or is it you don't have the right number of people?
It is the capacity to recruit. So if I could recruit someone, well, if there was the right person, obviously, I couldn't just recruit anybody, but yeah, Amy, come Amy. Come, Amy. Yes. So in the next couple of years, we do want to recruit like an academic urogynecologist. So the
10 fingers, 10 toes up. Yeah. I love Canada. I go there. I've been there like 6 times in the last 2 years.
And you haven't called me. called me.
I love Canada. I like every vacation I'm going there. Toronto, Vancouver. I'm going to Banff in June. Like,
the dollar exchange doesn't hurt.
Oh, $1.33. Yeah, I know. It's really
a free
good.
trip for you.
Yeah, Lululemon is like $70 instead of $100.
I know. A beer might be like $1.50.
I know. Is it like, how many days of block time are you talking about? Like, because it seems like there would be very funneled, like a conversion rate of like 80%. Because here, Mings is like 80% or 90% go to surgery. Urogyn, I would say it's more like, depending on the day. I mean, earlier in the year, it might be 20%. As the year progresses and the deductible goes away, it's more like, or gets used up, it's more like 30 to 40%,
You're talking about the number of patients per day in a day of clinic that will end up getting a surgery
Going to the
order.
OR.
Conversion to surgery. Yeah.
Yeah, conversion to surgery.
Yeah, I think Urogyn standard is about 30%. I think, remember I used to do some of that. For MIS, it depends on the nature of the practice. So there is a lot of, especially with pain patients, there's a lot of medical management. Our people are quite good at it because, again, they have to keep them stable for surgery for 18 months beforehand. We see end stage stuff as well. So we see a lot of people who end up needing bowel resections and stuff like that because by the time they get to us, it's been quite a long delay. But then while waiting for us, things can progress as well. We need to build more capacity to recruit certain subspecialties. Now, I'm going to tell you, I wholeheartedly believe you have to fix your internal capabilities first. Like, I think there's a lot of efficiencies that we can work on and things of that nature, like, or even better yet, how to effectively provide regional triage. So like, we see a lot of people who live very, very far away because they don't necessarily offer the service there. So we're training a lot of people. Hopefully that network changes over time. I can tell you it has already. Like, our fellowship has graduated a lot of really good people across the country, most of whom are academic or academic affiliated. Some are in Toronto. And so we're redistributing some of these higher complexity cases organically. So that way people don't have to, like, we see people who live 8, 10, 12, whatever hours away or farther out of province too. So that province is a state. That's a state.
Yeah.
That's a state. And
wait, so how many days of block time does each surgeon have? Like 2 days a week?
It's varied, and that can be a sensitive subject for sure. But as it is anywhere, we try to create paradigms where, like, people who are recruited as surgeons don't do obstetrics, don't do other things, get more operating room time because that's their job to be done, and that's how they make their money. Now, the OR makes less money than clinic here, depending on what you do, but it's still it's your job, it's your craft. So you have to be able to provide that for someone to do that. Like, someone in a good month who might get, like, a pure surgeon will get somewhere between like 5 and 8 days a month in the OR. A general OBGYN, and this is sort of the city standard because, like, I know what other people do, it's like 1 to 2 days a month.
But you're getting a couple days a week or less. I mean, 1.5 days a week.
Yeah. Like a typical surgeon, yeah. And we try to equilibrate as best we can Urogyn OR and MIS OR and things like that. It's right now our Urogyn, we're trying to repair their really bad wait times. And so, because they really suffered over the pandemic a lot, right? Because it wasn't considered life and limb type surgery. So, but our hope is that by, in the next several months, that'll be a lot better shape.
So, like, when you talked about the medical management and the managing the expectations, I will tell you, we share the nurse triage with, all of our colleagues, and the MIGS patients are so unhappy. They like overwhelm the nurses with their unhappiness about the anemia, the bleeding. Each period is like a bomb going off, of like needing a transfusion, the pain. I mean, and then the poor nurses are like, we can't move of your surgery, but it's like a huge problem, And so I hear you on this. And I know Nucelio is in your group, and he's doing all that gnarly neuropelviology stuff with you guys. So I'm sure that skews your referrals quite a bit too. I mean, Ashley Goebbels is in our group doing the neuropelviology stuff too, and doing pudendal neurolysis. I mean, it is.
Are you doing a bunch of that stuff?
It depends. We do a lot of nerve-sparing severe endo. If it's something that's really strictly nerve impingement, which is very specific, then I send them to him. But he also does Urogyn. Yeah. I gave that up when I moved here.
Yeah. I mean, I think that your descriptions of the system is extremely interesting. The other question I want to ask and circle back to is regarding oncology. Why are they semi-salaried?
It predates me. I think,
Can you explain what that means, semi-salaried?
right. So we have something called an AFP. And what that means is that academic centers are given additional funds from the Ministry of Health historically to offset the difference in income from the community practice for an academician, right? Because if you're in an academic setting, high acuity, low volume, research, education, administrative work, things like that. So they give you a certain amount that's distributed departmentally based on the number of people you have. And so our department, we use it to recycle for academic purposes like fund clinician investigators, things like that. Education, what have you. And there's and that's through things called a practice plan. Some departments in the US have a practice plan. There are group AFPs. So group AFP is whereby a certain number of doctors are funded at X amount per annum salary, negotiated by some means through the Ministry of Health. So GYN Oncology specifically, many moons ago, were at the verge of collapse. And so I can't speak to the details, but there was a crisis, and it resulted in an absolute negotiating with the Ministry of Health. And they landed on a salary model whereby the physicians are salaried X amount, and then they shadow bill. So for every episode of care, they bill whatever it might be. Like, I'm making this up, 30 cents on the dollar or whatever. So let's say, you'll get X amount lump sum or divided however, which includes so many weeks of vacation or academic time that's negotiated with your group. And then you bill on top of that a percentage. So the thing with GYN Oncology, however, is that you can't just hire more and more. The ministry says how many you can have. So you can have X number of positions at University of Toronto, Mount Sinai, University Health Network. Oh, we realize you need more. Okay, you can recruit another oncologist now. So then you have to have the resources or capacity to bring on that oncologist as well. So you can't, it's all predetermined numbers.
So if you train in GYN Oncology in Canada and you get out, there's no jobs. If there's no one that needs one, right, it's kind of like you're at the whim of like what the ministry says is needed.
Based on whatever hospital. So yeah, but the same sort of, yes, we have a lot of people do locum tenens here after graduating. We have orthopedic surgeons, I believe, right now are in a pickle because a lot of them are doing like 12th fellowships because there are no positions in the city. You might be able to find a position somewhere far out in an underserved area, for example, but if people don't have family there, they're not inclined.
And they don't get paid more to go out there, right? You're just saying it's kind of like,
correct.
This is what this specialty gets paid, period, wherever you're working within this province.
Well, they don't get paid, they bill. There's no salary. Like, that's what I'm saying. Like, the only truly salaried people are like microbiologists, pathologists, people who are not patients. Like, they don't see patients.
Eat what you kill.
Eat what you kill.
And do you have an RVU? Is there a similar?
No such thing. Dollars.
And is there a set fee for a hysterectomy?
Yep.
Is it based on like size?
Approach. So open, laparoscopic, different types of vaginal reconstruction. And historically, the laparoscopic wasn't that much more than an open. It got a little bit better. There's some negotiating that's changed it a little bit.
It's the laparoscopic is the least in the U.S.
Is it right now?
The idea that
58665. I don't know. I'm reaching back. Yeah. CPT
because
codes.
the way that those codes are billed, they add on the number of average hospital days. So like an open HIST, you get 3 days. So the HIST is only valued, whatever, 8 or 9 RVUs, but then they add like 3 outpatient visit days basically on top of it. So you actually get paid. There's more RVUs associated with an open HIST than a laparoscopic HIST. I think vaginal HIST is in the middle, but TLH is the least. it takes the most, not most, but takes more training, sometimes the most complex, and it's reimbursed least because when they did the surveys, people, I sent them home same day. It's like, no, don't say that. But now CMS is like, all right, well, then we're just not going to pay for those days or for that hospital day. So it's actually reimbursed the least.
It's similar-ish here, but there's the facility side, or what the hospital makes, things like that. But the hospital systems like ambulatory surgery we've converted almost everything to outpatient. So like we're actually toying with the idea with one of our colorectal surgeons, although I don't think he quite really knows this, how we can do bowel resection with some home health services on an outpatient basis. But
that's bold. I like your bold.
Be very, very quiet.
Don't worry, no one listens to this show anyway.
Oh my God.
No. Like we have to. So the thing that motivates me, and I would venture to guess, Mark, you're like that. Like what's been stifling over the last few years is that we've been particularly in problem solving mode rather than generating creativity. Like I much prefer, I'm so tired of solving problems, but in my role, your role, like we're firefighters, right? Amy, we're all firefighters, but I still am motivated by like the creative soul. And, it's stuff like, that's nothing, I'm just saying, but like, how do we do things better? Like, it's just it's every now and again, it's that crazy little thing that you didn't think of, or that you didn't think would do anything that translated into tremendous benefit in some form.
No, I think that definitely is what drives me, especially in my new role, just that you start to see like, if I move this thing that way, or if I, if we change sort of how people do things, it's the same idea, just on, by scale, and I think that's something that just in my career, 12 years in, 13 years in, it was like, my brain was like, this is, you're curious about this now all of a sudden. But yeah, trying to get a group of people to do a thing you want to do while still providing that care, because it's not the same degree, but in Kentucky, we have patients that come from hours and hours away. Access to care there is like, at least from, an American perspective, is the remoteness of Appalachia is something that is not seen in most parts of this country. Like access to care, there's just not a hospital.
Right.
Or people just don't even go, right? Like our GYN oncologists are very busy, right? Because they have folks that haven't seen doctors in 20 years. But so the wait times are for little different reasons. But access is a huge issue. That's our number one issue. We have more transfers to our hospital than anywhere else in the country, I believe. And you always want to say yes, but there are only so many beds. There are only so many ORs. There are only so many techs and travelers that you can get to work to do the work. And it's like, I want to help. I want to do more, but I also have to, have enough in me to want to wake up and come back and do it the next day.
When we moved here, I had a pretty good idea of what I was walking into. You never really know until you're knee deep. And the things that really just bother me to no end and, eat at your core. But what's always nice in a not nice way is that, you talk to colleagues, you talk to friends, and there's always a struggle no matter where you are. Right? Like it depends on what that struggle is. there might be different flavors. Like people idealize the idea of Canada right now for various reasons. So we all have shared grief, and I think that is one, because we care, I think, and two, because both of our systems are really plagued with different issues.
Well, I appreciate that. And I think, moral injury comes in a lot of different flavors for sure. And, I don't think there's a perfect. I think that it depends on which side you are on, depending on where your need is, right? If you need primary care versus if you need, a super subspecialized thing versus where you live and what your resources are. It always, there's always winners and losers in any given system. But there's no question, though, it is a business, not just here, but I think in anywhere you go. Thinking about, you mentioned robots earlier, right? But like, I would imagine there is no bigger cost center than a robot in Canada, right? There's just no benefit. And for our listeners, I'm not sure that's the robot though. That's more like, I don't know what dance that is. There you go, Amy. Amy's teaching him a little bit about what robots are. He doesn't even know.
No, I do.
You don't have robots up there. He has no idea.
I can tell you my robot story, but
well, no. I mean, so talk to me a little bit about robots in Canada, because I know years ago I was at a suturing course talking to a handful of fellows and some faculty from, I want to say, Vancouver, and they were like, yeah, there were like 4 robots in Canada. It's been a few years, but like, is it still less common to have Da Vinci systems in hospital systems? Or are they everywhere by now, or what's going on with that?
If you haven't read it, you might very well have. I'll share it with you. The 2021 Cambridge report, it looked at the effectiveness of healthcare a little bit more subjectively, as opposed to just like mortality or whatever. Have you seen that report? It's actually quite fascinating.
Yeah, send that to
Remind me and I'll send it to you. But it really shows. It looks primarily at developed country healthcare outcomes in fairly granular detail. And Canada and the US are at the bottom of it. I mean, this is a few years ago, but not that long ago, 3 years ago. I'll send it to you. With regards to robots, so, I had my little fantasy list of when I came up here of the things that I would need. And I got to say, like, the people who brought me here really lived up to it. And then, a lot of it was earned, but we really were able to make a lot of change in a relatively short period of time. The robot was one of them.
Were you doing a lot of that out at Cedars before you came, or was that?
I was like a 50-50 guy, just because we didn't have a fellowship at the time, and I wanted to make sure residents got a lot of laparoscopy or whatever other vaginal surgeries, hysteroscopy, so I'm not a purist in that sense. And so it served me well because I had none when I came here. So I would have been SOL, truthfully, if I didn't. And I learned different skill sets because the diseases here are a bit different. And so
really, what?
I don't know. We see like
frostbite,
and yeah, it's like I use Vaseline in the winter. I'm not joking. Like they put Vaseline on my hands. The nurses showed me this because your hands, this. You live in the cold, Amy. But I never had that before. So that's what. No, but no, we just it's just like the endo here is different. It's really, 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 really bad. We had bad endo there, but like here we have everything put together. We have bad endo, adenomyosis, fibroid, everything just like put into one tiny little person. And so it's just very hard. I mean, I'm used to it now, but when I first got here, I was blown away by the level of complexity and just how much of it. Like you just go to an OR, you're like, all right, this is a resonant case, or, you just let the fellow do it. And then you start, you're like, oh my God. Like you never get a break. It's just, there's a lot of hard stuff here.
Do you think it's because of the delays in care?
I think it's a combination of genetics, and like we see a lot of Southeast Asian Indian here too. They have really bad season, the delay. Yeah, both. But with the robot, it took us 6 years. We finally were able to move forward in 2021. We're actually one of the only hospitals that I'm aware of that a lot of the push and emphasis was on benign gynecology. So it allowed us to recruit a uro-oncologist. So our hospital is comprised of a lot of very good reproductive urologists, and we had one very, very internationally renowned uro-oncologist, but he only does things open because he gets the worst of the worst. But he was amazing. Like he just operate with us and teach, and he didn't care if we were doing it laparoscopically. We've actually got a great, great, great team here. I couldn't be luckier, to be honest, with GI surgery, urology, everybody. We have a good group. But we were able to recruit a phenomenal Canadian but US trained uro-oncologist in robotics, and he's been such value added to the team. And so now we're fairly operational. We actually will need another robot again to recruit another urologist and others. So general surgeries now doing robotics, ENTs on robot for specific.
Well, I guess now they have the pay-per-click model. I wonder if it's easier for you guys to justify getting a robot. I don't know if you guys have the same sales model, whereas you used to have to drop $3 million, which is tough probably for a fixed budget.
It's philanthropy for that, just like the US. It's operationalizing that's the challenge. We do get a little bit more for specific robotic funded cases, but there are only 3. And that just happened like a year and a half ago.
I find it fascinating how you talked about 50-50 for robotics and conventional laparoscopy, but like talking to my urology colleagues here, they just don't do any lap. So it's like, if you don't have a robot, you cannot recruit urology, especially uro-onc. They just don't do, like, we get the fellows and, the female urology fellows, and they just have no interest in lap. They're never going to do it again. So it's like, it's useless for them to do a conventional laparoscopic sacrocolpopexy. They're just like, I'm never going to do it. So, it's fascinating. Like, when I first started my job in DC, there were certain old school urologists who are no longer there, but they would do some cases like the total nephrectomies or transplant with lap, but now they won't. They only do robot. So it's like you said, you have to buy a robot in order to recruit them. It's crazy.
No, when I was at the Da Vinci meeting.
The Da Vinci meeting?
Yeah, the summit.
Oh, the summit, yeah.
They invited us out. And a buddy of mine, a resident we had trained in general surgery, was out in Eastern Kentucky and said, in our hospital, unless we have robot time, we can't hire a general surgeon.
Wow.
I was like, what do you mean? He goes, no, like literally 100% of the surgeons we interview, like it's a non-starter. If we don't have a robot OR time for them, they won't come. And I was like, for general, I'm thinking I'm listening to Arnie talking GYN stuff. Like, yeah, a lot of our residents are coming out, they want it. Like, they're just not as comfortable with straight stick in general. But for general surgery, that's mind blowing to me.
It is.
My friend I just talked to her. She has bilateral inguinal hernias, and she saw this guy in Cornell who's a robotic hernia guy, and he was like, well, you have to go under general anesthesia, and there's a less of a recurrence rate, but it's a higher complication rate, and I think we should do robotically. And she was like, what? I texted my friends who are gen surg here, and they were like, well, in women, bilateral inguinal hernias, you can cover the femoral space as well, and it's better than doing open, and in his opinion, open is also fine, and robotic is only of benefit in complex revisions. And I was like, okay, that makes sense. But whatever the sell was to my friend, who is a psychiatrist and a very well, versed in medicine kind of person, was like crazy. I was like, oh my gosh, when all you have is a hammer, everything looks like a nail. Like, it's crazy to me about the robot.
I have a very good friend in LA who I used to work with. She's a hernia specialist, but they'll do lap mesh. Right?
Yeah,
smaller incisions and not the whole
Giselle
big.
Hamad. Yeah, she did a ton of lap hernias.
But we're lucky here. Our colorectal guys all straight stick. Our hernia guys all straight stick. Like, when I came back here, there was one robot at the hospital I didn't operate at. So for 7 years, I had no robot. I come from Michigan, where they had like 12
right
years ago, and I was like, hey, can we do some of these straight stick in training? Because I was like, I have a robot, and I got really good. But we had great people. But if you ever called urology, they're like, they're just like point at stuff. They had no idea. Like, I was closing a cuff one time. I was like, hey, I'm going to have you, let me just do this real quick so you guys can go do your thing. And I heard him lean and whisper to his resident, he's making that look easy, but that's really hard. Like, I don't think they'd ever suture laparoscopically in their lives, right? They're just not used to it. But
last thing I'll say is we're seeing a change. When I first came here, the idea of the robot was poo-pooed. I spit on your robot. Like, there was no concept in those, because there was no evidence and blah, blah, blah. But I think to some extent, the sense of competition and the sense of progress were ignited, and more gynecologists are actually benign gynecologists are getting robotic time at their institution. It's still a struggle, but it's like the US was in 2008. I guess,
but again, different incentives, different drivers, right? It's not lack of caring or ability. I think, again, you're given the tools you have and succeed, and it's just different priorities, different pay structures. But no, it's interesting. I think we had a meeting today. I was thinking, man, I'm excited to talk to you tonight in general, but specifically just to understand, like, how different incentives, how you can get systems will always make the thing you design them to make, right? Like, don't be shocked when that's what comes out of it. Like, you built it that way. So how do you redesign systems to get outcomes that you want in terms of, quality and those kinds of things versus just pure volume? So anyway.
How do you motivate your people? So like here, everybody eats what they kill. So like there's no financial incentive for anybody to do anything that you don't want, meaning like to invoke change or, things like that. So how are you finding that in your system where you are?
So it's changed over the years. The most recent compensation plan is, for the most part, eat what you kill. It's a base salary, and over your base salary, you get, whatever dollar per RVU it was negotiated or was agreed upon, or I guess assigned, really. You get that many RVUs over. And I think, and a lot of that goes to the department, and then the department sort of divvies it up and helps pay for all the overhead and admin, those kinds of things. But right, that's the challenge. There are, the chairs, there's some metrics that are tied to quality and those kinds of things. But I feel like that's the kind of thing that if we're going to change care, the quality of care, the way we provide care, then we have to probably change incentives. Because for a long time, there was no real there was no real financial incentive. If you made 80% of your RVUs that you were required to make, you kept your base salary. This is when I was hired. To bonus, you had to make over 120% of your RVUs.
Okay? Oh, wow.
Whoa.
Holy cow.
So between 80% and 120%, no difference, which means 81%, let's just shut this thing down. I'm done for the year, right? Because it doesn't impact my take home. I mean, when I first got started and I was really hustling, I made like 121%. I got like $9 or something. It was like, wait, what? I could have worked a third less for the same amount of money. I could have stopped working in like March.
Yeah.
And made the same salary. So I was like, again, that's not a system that incentivizes what you want, right? And so it was changed to be really a productivity, and we got busy. Man, this place got crazy busy. But okay, now we have to think about how we get people to do. So that's what I think about constantly these days. Is like, okay, we have to design it backwards. What do we want it to look like, and then how do we get people to do the things that we want them to do? And so really, it's a lot of the behavioral psychology stuff, a lot of those kinds of things to think about, and partnering with them. I think most people want to do good work. They care. They want good outcomes. Like, they're not. We have great people. I'm sure you do too. We're lucky.
Amazing. Very, very. Actually, that's the one thing I will say is like the things that I used to worry about in LA and the things I worry about here are very different in certain areas. But like the people that I've worked with across the board have been like truly, truly exceptional people. So I'm very lucky in that regard.
Me too. I feel the same way. I mean, I was in what Mark described, like a base salary with productivity over a certain benchmark. And it definitely infused the culture. Of course, I was in a great group. It was, all of us were very dedicated to the academic mission, research, education, clinical excellence. And then coming to the clinics when we're salary, I mean, man, we are set up for efficiency. Like, we have a lot of support for, just being really efficient. So,
but you also select for those kinds of people, right? So like over the course of decades, you bring certain people who want to work that kind of way versus other places where, like, come here, you can you can get home and pretty quick and make a lot more money. It depends on what the institution's incentives are and those kinds of things, and what the mission is, and to change that is hard.
Yeah. So we definitely have what you described of like having a great culture and recruiting workaholics, and people kind of know what they sign up for. You have to teach medical students, residents, and fellows when you come here. And, certain of our sites don't have fellows, but definitely there's education component because we're salaried.
So there's no bonus at all?
No. But the thing is, I just show up, I see my patients in clinic, whatever they schedule for me in the OR, I do my cases. It's because our surgical scheduler sets it up because it's a Tetris, because we have to do the pre-anesthesia clinic, the urodynamics, the pre-op consent, and then schedule them in around their vacation or whatever, their daughter's wedding or whatever it is. So, I should not be doing that. my surgical scheduler does all that and handles it. And then, whatever time I operate to, unless I have to go out of town, which is a different story. Like if I'm leaving that day for a meeting the next day or whatever, then I need to get out at a certain time, or we're traveling. That's another story. But I think that most of us are like that. We just work. And then but in my old practice, what we had to do was educational RVUs, and we had RVUs, academic RVUs assigned to certain activities like journal reviews, teaching at the resident education, fellows conference, because honestly, what you're describing about motivating people, it was hard sometimes.
I know how I'm going to get you guys here. 3 things. 1, the OR starts at 8 and ends at 3:30. You have to finish by 3:30. So you're done at 3:30 unless you're me and you run late. My name is Solnik, remember? And but you have control over your schedule, clinic schedule. Like if you want to see fewer people and make less, go home, take vacation, whatever, your schedule is yours to control. And a lot of people, not me, but a lot of people, if they have like cottages, they take like 3-4 weeks off every summer if they can. And they have a locum cover their practice.
No way.
I mean, people will always do, they'll always learn how to game the system, right? So if it's like at the VA where it's like show up, we'll pay you no matter what, people like, I couldn't possibly fit a second case in, like leave at lunch. Or because I was the GYN for our local VA for a bunch of years as well. It just, again, different systems will get out of people what they design. And so trying to figure out what that is interesting, and how we make those changes. But we could go all day. I know you're a busy guy, and you've given us a lot of time today. And for that, we're so grateful. But I want to make sure we get a chance to be friends afterwards. So we'll let you go. Such a pleasure. Honestly, we came with a bunch of questions. I didn't even look at them. This is just like, we just, boom, got started. And I learned a ton, as always, from you. Such a gift to get to spend time with you, and I'm glad to hear you're doing well and get and feel better soon.
Well, I love you guys, so it was a total pleasure to do this.
Awesome.
Besos.
All right, talk to you soon.
See you guys.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orvijinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.